Many rural American towns are defined by a quiet physical erosion, a reflection of economies that can no longer support their own infrastructure. At the center of this survival struggle is a massive financial dataset covering every rural and community hospital across the United States. More than half of these facilities are classified as critical access hospitals, a federal designation designed to keep the rural safety net from collapsing entirely. But the data reveals a contradiction. By standard clinical metrics, a significant portion of these hospitals are technically insolvent, yet their doors remain open to the public. Evaluating these facilities purely as commercial businesses fails to explain their continued operation. The math of patient care does not match the reality of their survival. To find the source of that survival, we have to look at two specific numbers. First is the patient services margin. This is the clinical reality, the profit or loss generated exclusively by treating patients. Then there is the total margin. This represents the subsidized reality, incorporating local tax levies, federal grants, and asset sales. Understanding rural hospital solvency requires us to ignore top-line revenue and instead measure the exact delta between these two metrics. This gap is the ultimate signal of how a hospital survives. It reveals that staying open is a matter of non-operating capital, not patient volume. Before we can map this delta, we have to strip away the data points that distort our view of the typical rural facility. We remove 53 Indian Health Service hospitals. Because they are federally funded and report zero margin data, they operate entirely outside commercial hospital economics. We also filter out Mary Hitchcock Memorial in New Hampshire. Despite its rural classification, it is a $2.6 billion academic medical center. Its scale distorts any typical analysis of a community provider. Next, we flag accounting errors. Mathematically, a hospital's patient services margin cannot exceed roughly 100% under standard accounting. This forces us to set aside entries for Lodi, Ohio, Gunnison Valley, Utah, and Baylor Scott & White in Texas, where reported margins exceed 300%. Manual scrubbing is necessary because these anomalies lead standard investment models to misjudge the actual stability of the rural health system. We can now build a model for the entire sector. On this scatter plot, the x-axis is the patient services margin, and the y-axis is the total margin. This 45-degree line represents parity. Any hospital sitting on this line lives or dies based solely on the clinical care it provides to its community. When we plot the actual data, the vast majority of rural hospitals sit far above that line. This vertical gap represents the exact volume of non-operating life support keeping the facility functional. In Alaska, this gap becomes extreme. Petersburg and Wrangell report clinical losses as deep as 18%, yet they maintain positive total margins as high as 50%. These facilities are surviving on massive non-operating inflows that completely decouple their financial health from their clinical business. We see similar spikes in Louisiana and New York, where hospitals like Lady of the Sea and Callicoon report total margins exceeding 60 and 120%, likely due to one-time financial events. The conclusion is clear. The rural hospital has ceased to be a commercial enterprise, becoming a federally subsidized infrastructure mechanism. Moving this data from a plot to a physical map reveals that these financial outcomes are not randomly distributed. Deep distress clusters form in South Alabama, rural West Virginia, Mississippi, Kansas, and remote South Texas. These clusters share a common economic baseline. The local economy has eroded, leaving the hospital as one of the last remaining pillars of infrastructure. The research identifies two key variables driving these losses: low county populations and high uninsured rates. In states that opted out of Medicaid expansion, these factors create a structural loss pattern that is effectively baked into the geography. In these regions, the failure of a hospital is mathematically predetermined by its zip code long before a patient ever walks through the door. Oklahoma illustrates one extreme of this geographic determinism. The Creek Nation facility shows a total margin deficit of nearly 69%, part of a statewide cluster of extreme distress. Even under federal programs, these Oklahoma facilities face some of the most severe financial pressures in the nation. Iowa presents the opposite extreme. Iowa's critical access hospitals are overwhelmingly healthy, with facilities in Anamosa and Dallas County reporting margins above 30%. This confirms a federal label like critical access is no guarantee of solvency. Outcomes are dictated almost entirely by the state-level policy and economic environment. When the gap between clinical reality and the non-operating safety net becomes too wide to bridge, the system finally fractures. We can use historical closure data from 2005 to the present to track the decay of the rural hospital network. The window between 2013 and 2019 was the worst sustained period for closures, marking a slow, steady erosion of the safety net. But the data shows a violent spike in 2020, with 15 confirmed facility closures in a single year. The pandemic stress of 2020 served as a catalyst. It finalized financial decisions that had been delayed for years in structurally compromised clusters. In the end, the individual commercial strategy of a hospital is secondary to its location. Rural healthcare is no longer a commercial market. Its future will be decided by how and where we choose to allocate non-operating capital.